A 49-year-old male patient with double mitral lesion was hospitalized with fever, cough, and worsening dyspnea. 1 year back, he developed dyspnea with sudden onset and medium exertions for 5 months, associated with dry cough at night, which was relieved with orthostatism. Now let's start with the general examination. Coming to general examination, let's check pallor by lowering the lower palpebral conjunctiva and ask the patient to look upwards, and icterus on upper bulbar conjunctiva by asking the patient to look downwards. Now we look for cyanosis, both central and peripheral. Central cyanosis, buccal mucosa, tongue and lips. Then we look for peripheral cyanosis in palms. Now for clubbing, we'll ask the patient to approximate the nail beds of both fingers and check for Loewe bond angle. Coming to pedal edema, we give pressure with the thumb on a bony prominence, that is medial malleolus, for 15 seconds. In the presence of pitting type, we can see depression. Coming to pulse, we use 3 fingers. Index finger for obliterating, proximal to heart, middle finger for palpating, ring finger for emptying, placed on distal lower end of the radius. Now we examine for radial pulse in semi-pronated hand. In pulse, we check for rate, rhythm, volume and character. In JVP, keep the patient at 45-degree angle and turn the patient head towards left side and place one scale on sternal angle and check internal jugular vein pulsation between 2 heads of sternocleidomastoid and check for highest point by placing the scale perpendicular and measure distance between this point and sternal angle. For BP measurement, airbag should extend 2/3 of the circumference and length over the brachial artery and see that patient's hand should be in same level. Palpate radial pulse and raise the pressure up to 20 mm Hg first and then raise the level until no pulses are felt. Increase the pressure up to 30 mm Hg above the level at which the radial pulse is extinguished. Place the bell or diaphragm of the stethoscope over the brachial artery. Open the control valve so that the rate of deflation of the cuff is 2 mm Hg per heartbeat. So, systolic blood pressure is the appearance of the first Korokov sound. Diastolic blood pressure is the point at which the sound disappears, which is 5th Korokov sound. The respiratory rate, we'll see abdominothoracic type of respiration. On inspection, we check for both carotid, thyroid and position of trachea. On chest, we check for shape and symmetry. Movement of chest on respiration. Look for pericardial bulge. Check for dilated veins, scars and sinuses. Look for apical pulse in 5th intercostal space, 1.5 centimeters medial to midclavicular line, and any other pulsations. Like suprasternal, supraclavicular area, parasternal, epigastric and pulmonary aorta. In palpation, first we see the temperature, tenderness, and then palpate the anterior chest wall by palm. Tip of the fingers is used for pulsations, base of the finger is used for thrills, base of the hand is used for heaves. Now palpate in all areas. We palpate apical impulse with hand and locate apical impulse with finger, which is felt as hyperdynamic, that is shifted to downwards and upwards, which is normally felt 1.5 centimeters medial to midclavicular line. Check for palpable heart pulsation. In aortic area, right second intercostal space. Pulmonary area, left second intercostal space. Apical left fifth intercostal space 1.5 centimeters medial to midclavicular line. Epigastric area. Check carotid pulse by palpating right carotid artery by left thumb. Left carotid artery by right thumb. Now we look for parasternal heave in the left side. In parasternal area, using the ulnar border of hand and correspondingly on right side. Percuss from above downward in midclavicular line up to liver dullness. Now go one space above the liver dullness. Change the direction of percussing finger parallel to the heart border and move medially till you get dullness. And now percuss for the left heart border up to the anterior axillary line. On auscultation, check for heart sounds and murmurs. In aortic area, second intercostal space to the right sternal border. In pulmonary area, second intercostal space to the left sternal border. Tricuspid area, fifth intercostal space to the lower left sternal border. In mitral area, it is present at apex, fifth intercostal space at medial to midclavicular line. We can hear pansystolic murmur. In Erb's area, third intercostal space to the left sternal border. Check for heart sounds and murmurs by using bell. Aortic area, second intercostal space to the right sternal border. Pulmonary area, second intercostal space to the left sternal border. Tricuspid area, fifth intercostal space to the lower left sternal border. Mitral area, it is present at apex, fifth intercostal space at medial midclavicular line. We can hear mid-diastolic murmur. Erb's area, third intercostal space to the left sternal border. Auscultate for mitral stenosis in the left lateral position when the breath held in expiration using the bell of stethoscope. and time the murmur with carotid. Auscultate for mitral stenosis in the left lateral position when the breath held in expiration using the bell of stethoscope, and time the murmur with carotid.